Hey, good morning, everyone. I think we're going to get going here. I just want to start off this morning by thanking Dr. McGee, who has been a champion of this event. This is our 10th annual Department of Surgery Research Symposium. And he will be introducing our very distinguished visiting professor, Dr. Leslie Dossett. Of course, other people helped Dr. McGee. They're all M's, by the way, Dr. McCarter and Dr. McIntyre. And Kathy Tuttle, thank you for arranging last night and arranging this event. You and your team have done a great job. Thank you. Rob?
Good morning, everyone. Thank you, Dr. Schulich. Today, for our 10th annual Department of Surgery Research Symposium, we are really honored to have Dr. Leslie Dossett joining us. Dr. Dossett is the Maud T. Lane Research Professor for Cancer Quality Improvement. She is also the Chief of the Division of Surgical Oncology at the University of Michigan. Dr. Dossett hails from Kentucky. She earned her medical degree at Vanderbilt, where she stayed and also performed her general surgery research and an MPH in dedicated research time. She subsequently applied for and has a K Award, an R01, and is the mentor on several training grants and research mentee, has many research mentees. Now, something that's interesting about Dr. Dossett, she and I have met over the past few years through the Surgical Outcomes Club. She's very humble, and something that I did not know until last night is that she served in the United States Navy as an active duty general surgeon, and she took 4 years off between finishing her residency and starting her fellowship to complete her duty that she had from the scholarship she achieved. And she actually was deployed overseas several times, including in a forward Marine combat unit at one juncture. She subsequently returned to the United States. She completed her surgical oncology fellowship at Moffitt and then joined the faculty at the University of Michigan, which she initially met as she was working on a research training program mentored with partnership of mentorship from a faculty at the University of Michigan at the time, who recruited her after her graduating from her fellowship to become a faculty at Michigan. At Michigan, she's a lauded clinician, investigator, and teacher. She specializes in complex cancer, including melanoma, sarcomas, and breast cancer. We were sharing sarcoma photographs at dinner last night. Her research centers on healthcare delivery and decision-making, particularly in low-value care, and she's going to present to us today. And again, she's the co-director of the Michigan Program for Value Enhancement. She works to translate research findings to the bedside to improve value of care for patients in Michigan medicine, as well as nationally and internationally. Within the Department of Surgery, she has several roles, like many of us do. She serves as the vice chair for faculty development, overseeing recruitment, mentorship, and leadership development, as well as culture building. And then she's an active member of many national societies. And again, she's the president of the Surgical Outcomes Club right now. She currently has funding through an R01 through AHRQ. She's the co-investigator and mentor and co-PI on several other NIH and ARC institutional grants as well. Please join me in welcoming Dr. Dossett to present this morning. That is it.
Thank you so much, Rob. Thanks for having me. It's great to be back in Denver. I was thinking, I was thinking as I was flying in last night, the last time I was here was interviewing for general surgery residency a long time ago, before the campus had moved here. And so it's nice to be back and see all the beautiful buildings and reconnect with a lot of folks from my past. So I'm going to talk, as Rob mentioned, my research portfolio really centers for the last 5 or 6 years, mostly been focused exclusively on this concept of low value care and de-implementation. This is one of those areas where I sort of stumbled into, and when I did, I recognized how much it aligned with my personality. I tend to be a minimalist, both personally and as a clinician, and thinking about de-implementation, how to stop doing things that are unnecessary, just really was fascinating to me. I'm going to share an example of some work we've done in a particular clinical topic, but I think everybody here, a lot of the concepts will resonate with you. I'm sure you can think, no matter what your clinical niche is, that you can think of things that we do that probably aren't beneficial to patients and are potentially harmful. So I'm going to talk about, too much surgery, how we can improve value by doing less. And Rob mentioned some of the funding organizations that supported the work, including we're very fortunate in Michigan to have quality collaboratives supported by Blue Cross and Blue Shield, and some of the data that I'll present is from the collaboratives. So I just want to frame this problem and why this is important. Healthcare spending, as I think everybody in this room knows, is growing faster than the rest of the economy. And I'll tell you that I've given this talk a few times, and I often sort of blow past this slide a little bit, but I was heard a lecture on Friday by Gil Welch, who's really a leading scholar in overdiagnosis of cancer. He's an internist currently at the Brigham and has numerous New England Journal papers on cancer overdiagnosis and overscreening. And, he made the point that if we truly care about social determinants of health, which I think, we do, that sort of controlling the amount of money that healthcare takes up in the economy is really important, because we're probably never going to meaningfully address things like housing, education, food insecurity, and whatnot if healthcare continues to take a bigger piece of the pie. So just keep in mind that healthcare spending is growing, and it's competing for other dollars in our economy. And unfortunately, in the U.S., I think also doesn't come as a surprise to you that additional spending here in the U.S. doesn't often translate to better health outcomes. We tend to be in sort of lower half of outcomes for many sort of key quality metrics as compared to the rest of developed countries. And that lecture, that reason or the sort of reasons for that are multifactorial. But at least one contribution is from overtreatment and low value care, which is going to be the focus of my talk today. And you can see the estimates are quite large, that there's actually a significant amount of waste in our healthcare system. So what is low value care? Well, it's often definitely in the eye of the beholder. People have different lenses on how they define value. And they look at different outcomes for measuring that. But there are areas where there's pretty wide consensus on some areas of low value care, and I'll talk about some of those today. But in general, we're talking about services that provide little or no benefit to patients, and importantly, I think this is important as clinicians, have the potential to cause harm, obviously incur unnecessary costs and waste resources. But I'll just have you consider that in general, clinicians tend to overestimate benefits and underestimate harms of treatment, and so we need to always consider the harms of our treatments. So I'm going to talk to you today about de-implementation. What is that? It's sort of related to implementation science, but it's not exactly the opposite. And I'll give you some reasons for that. But it's basically the science of identifying the factors that contribute to persistent use of low-value services, and then developing and implementing evidence-based strategies that can target these behaviors and then eliminate the practice. And one example I like to use is the case of low back pain. So there are many multi-specialty recommendations that indicate that for low back pain in the absence of red flag symptoms do not require advanced imaging such as MRI. Yet despite these multi-specialty recommendations, use of this advanced imaging remains quite high. And why is that? Well, there's a number of reasons. Oftentimes clinicians may have uncertainty about whether or not those red flag systems are present. Habit, time, skill, incentives, and momentum Clinical momentum is a big thing. And once the patient's in the emergency room, you feel like you have to do something. Oftentimes, it takes more time to talk a patient, out of doing the advanced imaging than just getting it to begin with. So these are all factors that contribute to that. And there's an evolving body of behavioral science work that supports the notion that it's actually much easier to start doing something new than it is to stop doing, something that's entrenched. And so we really face a steeper climb in terms of de-implementation rather than implementation and things to do with habit. And if you look at the de-implementation work that's been done, it's primarily been done in looking at low value laboratory testing or imaging, as the example I mentioned, or low value medications. And when you look at those, when you consider those sort of clinical enterprises, there are a few things that are a little bit different that or some strategies that can be used in those situations. For example, if you have a low value medication, it can just be simply withdrawn from the market or never get to market in the first place. And there's a few things about surgery, how we introduce new technologies to the field and how we pay for that make de-implementation of surgical procedures even more difficult. A few examples I give you. One is how we get new technology to the market. And so the bar for introducing new technology, such as a surgical robot, is really demonstrating safety, not efficacy, as compared to other standard of care technologies. And so what that can lead to is you can have wide dissemination of a certain technology or device before there's really evidence that it's more effective than what's currently on the market. There's this concept too in surgery, this Lake Wobegon effect. Have you ever heard a surgeon say, well, I know that in that randomized control trial, there was no benefit to that approach, but the way that I do the procedure is a little bit different, or I have different outcomes. And so because there's so much technical component, sometimes it can be harder to translate that evidence into practice. Obviously, in surgery, the incentives are aligned to do procedures. Actually, I think the department tweeted out something about this talk today, and a surgeon from Seattle, Washington, replied to the tweet and said, if you want to get surgeons to do less surgery, then pay more for clinic, right? And so evidence that the incentives are definitely aligned with doing more. And then the last point, that sort of recall or market withdrawal, some of the strategies that are useful in other settings just aren't amenable or just aren't available in surgery. An example of this I like to use is the laparoscopic gastric band. Show of hands, how many people have put in or taken out a band? Few. Yeah. Okay. Good. These were super common. We were putting in a lot of these when I was a resident. And this on the left is some work done by my colleague at Michigan, Andrew Ibrahim. And what is highlighted in that red box there, these are from Medicare claims. And as of 2008, Medicare was paying more money to take bands out than to put bands in. And so a real signal that this is probably not a great procedure at the time. But you can see that on the right, when you look at the various proportion of various weight loss procedures, that it wasn't really until 2011, 2012 that the rate of lap bands really started to diminish. And why is that? Well, one strategy for de-implementation is replacement by something else. And I would argue that as gastric sleeve came to practice, that was sort of what really ultimately led to complete de-implementation of the use of bands. So now that we have sort of this idea of some of these low value practices and de-implementation, I'm going to walk you through a clinical scenario that we've been working on for the past few years in de-implementation. And we'll use this framework where we really identify these areas of low value care, measure them at the local level, and then do what is often a lot of qualitative work to discover the behavioral determinants. A lot of this gets into behavior at the level of the individual or clinician. And then once we figure out those determinants, there's a body of work that matches those with behavioral strategies evidence-based behavioral strategies that work to address those particular determinants. But then we have to evaluate those strategies. And we do that locally, and then finally scaling. And again, I'll give you some examples of that. So I'm going to talk to you today about breast cancer. And when I first started thinking about de-implementation, part of my practice is in breast cancer. And I considered that at the time the Choosing Wisely campaign was sort of first coming and started getting a lot of attention nationally. And what I knew as a clinician was that there were 4 procedures targeted by the Choosing Wisely, by the breast surgery groups and Choosing Wisely as low value. And I knew just anecdotally that there were 2 things that we really never did anymore. You know, we had really very rapidly de-implemented. But then there were 2 other procedures that were still really persistent. And some of the things we talked about, like financial incentives, were sort of there for across the board. So it's really sort of piqued my curiosity of why did we stop doing those 2 things and not the others? And so that was really the entry into the space. And it turns out that breast cancer is really, I think the perfect test case for de-implementation and studying de-implementation work for a few reasons. First of all, it's very common, right? The most common cancer in women. And fortunately, it tends to present at a very early stage, largely due to cancer screening. And so it's, there's one thing that makes it nice. The other consideration that makes it a perfect area to study is that from a clinical setting, there's a long history of de-escalation in breast cancer care. This is supported by, a lot of very good funding for clinical trials. There are a lot of, most of these recommendations that you see at the bottom, if you're not in the breast cancer space, are supported by either randomized controlled trials or meta-analyses. So extremely high quality data that supports de-implementation. And then finally, breast cancer care actually primarily occurs out in the community. So it's not, esophageal cancer or complex HPV surgery that tends to get regionalized to just a few centers in the state. In Michigan, across our collaborators, we have 67 hospitals that perform at least 50 breast cancer cases a year. And what that does is it makes it really important that we disseminate all these guidelines to our community. Because of that, because it is occurring primarily in the community, it's mostly done by general surgeons who, for them, they tend to be low volume breast cancer providers. And fewer than 1% of the surgeons that do breast cancer in the state of Michigan do personally more than 50 cases. So again, mostly low volume providers. And then finally, it's very multidisciplinary, as you know. And so if we think about de-implementing something in one area, we have to make sure that we're not going to create sort of workarounds or downstream cascades with our multidisciplinary partners. And so for those reasons, we thought this was a really great area to think about de-implementation. I mentioned the Choosing Wisely campaign. It led to the publication of over 550 recommendations. These recommendations, if you're not familiar with Choosing Wisely, came from national specialty organizations. So all the organizations that you are a member of, ACS, SSO, ASBS, STS, they all were tasked with providing Choosing Wisely five tests, treatments, et cetera, that targeted low value care. And I know, for example, for SSO, it was the quality committee, for example, that put forward these recommendations. So these come from our national organizations. Here's the 4 surgical targets that were selected by various breast cancer organizations. A couple of these were put forward by the ASBS. One was put forward by SSO, and one by ACS. And so it's not really important that you think that you know exactly, the details of these 4 procedures, just that there were 4. And again, we've had sort of various effectiveness in terms of de-implementation. And so the first thing we did is we wanted to look at nationally, again, confirm this anecdote that I had felt as a clinician. And so we used the National Cancer Database to look at these 4 procedures trends over time. And what you'll see, the 2 that I mentioned that I felt like clinically we had really de-implemented, really rarely used, You can see on the left, axillary lymph node dissection after publication of the results of the Z11 trial, really rapidly de-implemented. And then on the right, the no tumor on ink, or, avoiding re-excision for patients who had a close but negative margin after lumpectomy. Also, that rate was already quite low. There was a little inflection point, but again, pretty low rates. And obviously, we don't expect any of these things to get to zero. But the other interesting finding, the inflection point, the dashed line you see is when the paper was published, but you can see that the inflection point was about a year prior. Thoughts to where that might be? So this is why they were published. I think I heard somebody say it. This is when the results were published at national meetings. And so it just speaks to how data gets disseminated into practice ahead of the sort of formal publication. But in contrast to those procedures, there are these other two things: contralateral prophylactic mastectomy and sentinel lymph node biopsy in older women that not only weren't decreasing, but even were increasing our exceptionally high rates. And you can see those two areas. And sentinel lymph node biopsy, which is the area that I'm going to talk about the most, you can see the rates extremely high, 80 to 90%. And this is, again, national data. So given that, I thought this was really fascinating because, again, things like financial incentive are really, there for all four procedures, and we had seen de-implementation in these other two. So I really wanted to focus on why were we still persistently using sentinel lymph node biopsy in older women with early stage cancer. So to orient you to this problem, or to this particular recommendation and problem, older women with early stage breast cancer are just fundamentally different than younger women for a couple reasons. One, it is very common. So a third of the patients we see in our breast cancer clinics are over the age of 70. But fortunately, 80% of these patients have favorable tumor histology. They're estrogen and progesterone receptor positive. They have an excellent prognosis. And because of that, because of the favorable tumor biology, their competing comorbidities, the risk that a woman over 70 with hormone receptor positive breast cancer early stage would die of their breast cancer is less than 1%. So this sort of creates a situation where patients at risk for overtreatment. And so where does this recommendation come from? Again, as I alluded to, lots of very high quality data in the breast cancer space. These are two randomized controlled trials that looked back. This is before we were using sentinel lymph node biopsy. Most of these women had axillary dissection for staging, but you can see there's no difference in outcomes in these older women when stratified by axillary staging. One of the reasons for that is because of the tumor biology. Older women have very low rates of nodal positivity as compared to younger women. Less than 10% of them have a positive node at the time of sentinel lymph node biopsy. And the vast majority of those that are positive are small microscopic deposits of tumor that would be easily treated by the other adjuvant therapy that they're getting. So that sort of low pretest probability is part of why we don't see improvements in outcomes. The other important finding that as we're learning more about, I think, tumors in general and breast being probably on the leading edge of this, is that lymph node status doesn't always predict tumor biology. This was a large study looking at scores, oncotype scores based on lymph node status. And basically, it's really the gene expression profile that really predicts outcomes rather than the nodal stage. So now, a lot of our treatment decisions are not even based on sentinel lymph node status, but on gene expression profiling. And this was sort of one of the most recent randomized trials where women with positive lymph nodes, postmenopausal women with positive lymph nodes, were randomized to receive either chemotherapy plus endocrine therapy or endocrine therapy alone, and there was no difference. Again, sort of reiterating the reduced role of sentinel lymph node status on adjuvant chemotherapy decisions. And this is extended to the radiation setting as well, that really, again, knowing the patient's lymph node status doesn't impact their adjuvant radiotherapy decisions or overall outcomes. So hopefully I've given you enough clinical data, many randomized trials, multi-specialty recommendations that we shouldn't routinely be using sentinel lymph node biopsy in older women with those early stage hormone receptor positive cancers. So our next step was then to sort of dig into this finding that we had seen with the national data, where we saw, again, persistently high rates of sentinel lymph node biopsy. And we looked first at variation among centers, and you can see that sort of, there's about 10% of centers that were starting to, use this less, to de-implement this with rates between the 30 and 60% range, but the vast majority of hospitals had rates that were over 70%. To explore this in Michigan, we used our data from our Michigan Value Collaborative, which is a statewide collaborative that is based on claims data. And you can see on the left, we had a lot of variation in Michigan as well. Those are the 67 hospitals that do breast cancer surgery. And you can see rates of sentinel lymph node biopsy in these older women ranging anywhere from 30 to over 80%. And one of the things when I give this talk in a breast cancer sort of where there's a lot of breast cancer clinicians in the room, a lot of people say, well, we like to use a sentinel lymph node biopsy to decide whether or not, we should radiate the patient. Although I gave you the data that the clinical trials wouldn't support that. But what we saw was that actually most places that overused sentinel lymph node biopsy also overused adjuvant radiation. And so they tended to be high utilizers of both low value treatments. And only, 3 hospitals in Michigan out of 67 had rates of less than 50% for both of those. So the next step, and I think the familiar face that you'll see there, was to understand at the clinician level, what were some of the things that are driving this persistent use. And so we undertook to interview breast cancer surgeons and a national sample of breast cancer surgeons to understand the things that they were thinking about with these 4 choosing wisely guidelines. And I'll just show you the data. We explored all 4, but I'll show the data on sentinel lymph node biopsy. So first of all, we demonstrated that some people, there was a true knowledge gap. They said, I'm not aware of any specific data that would support not doing a sentinel lymph node biopsy in these women. And again, I showed you a lot of specific data and again, an SSO recommendation to not routinely perform this. Some people said, if the patient wants it, if they're going to lose sleep over not knowing whether or not their cancer has spread, then yeah, I'm just going to go ahead and probably do it. I like this one. Well, my patients are healthier than the patients that were in the clinical trial. I see a lot of healthy 70-year-olds. They're motivated to live to 95. So I think, the clinical trial data probably doesn't apply to my patients. And then this is the classic surgeon, right? It's only going to add 4 minutes to the surgery. So I think it's reasonable to go ahead. So I'm going to go through some of those findings that we got again from the clinicians with some other work that we've done around patients and hopefully convince you that those attitudes and beliefs from the clinicians are actually myths that we can hopefully address through education and other behavioral intervention strategies. So the first is this idea that it's actually the patients that are driving sentinel lymph node biopsy use. So what we did next was a sort of a theoretical experiment where we asked women to imagine that you were recently diagnosed with breast cancer. These are all older women without a history of breast cancer. And your doctor tells you the cancer's small, it's got a good favorable prognosis and recommends that you undergo surgery to lumpectomy to remove the tumor. And then we asked a series of questions about their preferences regarding both sentinel lymph node biopsy staging and adjuvant radiation, which are both they're both national recommendations to avoid or de-escalate. And so a lot of women definitely, the sort of idea that there would be age-based guidelines resonated with me. They said, this is not going to be the thing that kills me. I've lived a good life. I'm an older person. I don't want to put myself through a lot. And so they really sort of understand this concept of competing risk. So it really wasn't so much the patients, or most of the patients anyway, that were driving this decision. So the next exploration we looked at was, well, are there some patients who just strongly prefer more medical services? I think that resonates with us, right? We have some patients that are always pushing for more treatment, and could we then sort of tailor our conversations to them, our interventions to these people? And so we wanted to explore this through use of what's called the medical maximizing minimizing preference. And this was a single item validated measure of how likely you are to want more or less treatments that was developed by some PhD sort of decision-making experts at University of Michigan. And they had tested this question in many, many other clinical scenarios. And so we wanted to explore this in our patient population. And so this is basically the question. It's, sometimes medical action is clearly necessary, other times it's not. And people differ about what they want to do in those situations. So in those situations where it's not clear, on a scale of 1 to 6, where do you fall in terms of wanting to wait and see, or lean towards taking action? And so based on how people answer this question, they're classified as either medical minimizers, moderates, or maximizers. And an aside I'll say is that one of my colleagues at Michigan, Susan Pitt, who's an endocrine surgeon, is studying the same phenomenon in clinicians, because I think while our patients are medical minimizers and maximizers, we as clinicians are as well, and sort of exploring some of the interactions there. So what did we find? Well, what we found is that the MM1 score was pretty predictive of what people preferred for their treatment. So our minimizers definitely are like, there's not going to be a benefit, it's really not worth it, and really didn't show any preference for undergoing these low value treatments. Whereas we did see a signal amongst the maximizers that there were some women who wanted to undergo, again, what was described to them as a procedure that was not routinely recommended, to just make sure they were doing everything they could. But the most interesting finding, I think, was both the patients, minimizers and maximizers, patients that had low utilization, so underwent neither sentinel lymph node biopsy or radiation, and the high utilizers. All of them really said they listened to their doctors. So they said, he didn't think it was necessary for the people that ended up omitting these treatments. He didn't think it was necessary. Whereas for the high utilizers, they just did what their doctor said. And so again, sort of dispelling the myth that all of this is patient driven, and emphasizing the role that we as clinicians have in persistent use of low value treatments. And this finding has been backed up in many, many, many clinical scenarios. So the next myth that I want to address is that sentinel lymph node biopsy adds only minimal time or cost to the case. I have a joke amongst my family that whatever I estimate the time is going to be, it's 4 times that. So the 4 minutes turns to 16. But more importantly, for this particular procedure, for those of you who are familiar with these cases, is that lumpectomy alone often can be done under just sedation, whereas usually most people, when they add a sentinel node, will do general anesthesia. It requires the patient in most places to go to nuclear medicine and get an injection. There's additional pathology processing fees. So it actually is a fair amount of additional services, even though we as surgeons feel like there's not much extra. So what we wanted to do to explore this was, again, using our claims data. We looked at women who were that were eligible for omission. We found most patients across the state undergo lumpectomy, which I think is appropriate and aligns with the national data. But I want you to focus your attention on the panel on the right, where we looked at 30-day cost for sentinel lymph node biopsy. And the addition of a sentinel lymph node biopsy increased the 30-day episode-based cost for that procedure by 30%. If they had adjuvant radiation, which we extended to 90-day cost because of the time period where which radiation is delivered, that increased their cost by 57%. And it was over 90% increase in cost if you did both. And so sort of this idea that the procedure adds minimal time or cost is just not supported by the data. The third myth that I want to address is that this idea that, well, those those de-escalation recommendations don't apply to my patients because I see some really healthy patients. They're going to live a long time. They want to play golf. They want to play tennis. I'm sure you all have those patients here in Denver. So this is that concept again of like Wobegon effect and thinking that, you know, your patients are above average or your results are above average. And so to sort of discount this, I wanted to go back to the original trial data. And this is one of the randomized trials that was conducted to look at the benefit of axillary staging and radiation in these women, which showed no overall survival benefit. There were 636 women who were enrolled in this clinical trial. And if you see the age stratification, nearly half of them were between 70 and 74. So on the younger end of the over 70 population. And if you go to the fine print of the New England Journal publication, that you see that as of the time of the publication, which was in 2011, the median follow-up for the group was 12, just over 12 and a half years. Some patients have been followed for over 16 years, and over half of them had survived at least 10 years, with a large proportion of the women still being in active follow-up. So I think if we think about what you have to do to be eligible to get in a clinical trial, we should be able to accept that these are healthier women that we're getting this data from, and they're likely to apply to your patient population. And importantly, several of the trials that I showed you on which the recommendations are based actually included women younger than 70, in the 65 and older group. And I predict that actually this recommendation is going to extend to all women as we move to gene expression profiling. But for now, very good data over age 70. So now that we have some sort of ideas of why these treatments persist, both at the patient level and at the clinician level, we wanted to sort of match these with evidence-based de-implementation strategies. And some of the ones that we honed in on based on the things that we had discovered from our preliminary work were these strategies over to the right. So the use of clinician scripts. So that when clinicians have a hard time of describing why a patient should avoid a test or treatment, we can help them with language. There's some precedent in the literature with this around staging scans for patients that are in surveillance, talking to patients about why that's not needed. We wanted to test whether we could talk differently to patients who are medical minimizers or maximizers, whether that might be effective. We wanted to address both the patient education and provider education pieces. And so these are areas where we began to explore. So for this concept, and I don't necessarily see Nicole. I don't know if she's here. Oh, there she is. Okay. So this was Nicole's project. I love presenting it. It's a really cool experiment. So when we wanted to test this, basically what we did was we recruited, for a survey-based experiment where we recruited 1,800 patients, and we set up our recruitment as an online sort of survey-based approach. We set it up to where our enrollment gave us an equal number of minimizers, moderates, and maximizers. So the first question you had to ask was the MM1, and then that ensured we got a balanced number of patients. And so what we knew from our preliminary work, qualitative work, and talking to these patients was that there was reasons why minimizers might choose something. For example, they might choose mastectomy over lumpectomy just to avoid future treatments like radiation. Whereas there are certain reasons maximizers choose things like they think they might choose a mastectomy for the belief that it's better at treating the cancer, want to remove it all. So we use this sort of these ideas about language and what patients were motivated in designing our tailored script. And so what we did was we gave people this scenario, and then we measured their preferences for sentinel lymph node biopsy and adjuvant radiation. And what we found was that only about 20% of all the minimizers and 45% of all the maximizers indicated a preference for sentinel lymph node biopsy, which is far below those national practice patterns that we see, again, indicating or emphasizing the role of the clinicians. But an interesting finding was that maximizers, the minimizers really weren't impacted by the tailored messaging. They had low rates of preferences for that, regardless of what script they got. But the maximizers who received the tailored messaging were 40% less likely to suggest a preference for sentinel lymph node biopsy. Again, taken together, suggesting that there is a role for tailored messaging, but that overall, much of this practice is clinician or provider driven. So in terms of improving our patient education, we found that a lot of one of the things that our patients were saying is that all the information that was available online was directed to younger women. There wasn't any sort of group specific information. One of my mentees looked at all the top 25 U.S. News and World Report hospital websites, as well as all the national organization websites like American Cancer Society, et cetera, and looked at all the information that was included about breast cancer patients on all these websites and found that no hospital websites and only one national organization even indicated any or included any information on omitting sentinel lymph node biopsy. And only 2 of the hospital websites and 2 national organizations included information on the possible omission adjuvant therapy. And so this can set up a situation where patients are reading ahead of time, they're primed to think that these treatments are necessary because that's what the websites say, not carving out special education for them. And that's as opposed to these websites including information on, for example, breast cancer in the pregnant patient, which is a different population with some different recommendations. So in order to address this and improve patient education, we tailored an information booklet with some decision support around that was specific to our older patients with early stage breast cancer. And you can see some examples of the language giving really specific numbers about, how often that these treatments would help. And some of this was depicted in sort of graphical format, information specific to them. And what we found was when we pilot tested this information booklet with our patients, we decreased our sentinel lymph node biopsy to 11% overall. Again, some clinician impact there, and decreased our use of adjuvant radiation to 33% at Michigan Medicine. So to sort of then address the clinician education piece, and I'll remind you that some of the clinicians that we interviewed nationally were not even familiar with the recommendations. We wanted to provide some data, so we provided a sort of multi-component educational intervention directed towards them, which included information on the rationale for the recommendations, and you can see that we've had substantial reduction in sentinel lymph node biopsy locally. And this also included a strategy of audit and feedback, which is when you can show clinicians that there are other places that have de-implemented this safely. That tends to work as peer comparisons are very effective de-implementation strategy. These were some examples of our provider scripts. And, we don't expect clinicians to sort of memorize these and bring them in and read them to the patient. But sometimes as you're going into those conversations with patients, it's good to just read through this and remind yourself of some of the key points and data and think about how to frame this decision and recommendation to the patient. And then we also included a geriatric assessment that patients could use, because it turns out that most clinicians overestimate their patient's functional status, and that if you actually objectively ask people their life expectancy, that's been validated in numerous, again, clinical settings, that we tend to overestimate life expectancy. And so providing this in objective format made clinicians more comfortable in supporting the recommendations of omission. And we tested this in some preliminary fashion with multidisciplinary providers across the state of Michigan, and overall the materials had very high acceptability. And clinicians were very motivated to use them and had overall positive feedback. And our next steps are to test some effect across the state. So finally, and sort of get to the last step of this, we've we think that all this data, obviously the empirical data for de-implementation is quite strong. We think that we have identified the key determinants of this behavior at the clinician level, the patient level, and even the facility level. Some of this is group consensus and social interactions between clinician providers. So our next step is to sort of package these strategies and test them through what's called a step-wedge randomized trial throughout the Michigan Surgical Quality Collaborative. We're working on the funding for this. We actually have a separate body of work around low-value preoperative testing where the grant has been funded, and we've started this sort of similar work. So we're excited to get out to these hospitals and look to scale these interventions. So thank you for having me, and look forward to any questions.
Dr. Dossett, thank you so much for your presentation this morning. Very eye-opening. Before we get to questions in the audience, what advice can you share with the junior faculty and the residents and trainees about getting involved in and focusing a career on health services research, and in particular, and then also use of application of de-implementation for other projects?
Well, I think, obviously, I think people, whether it be in the bench science or health services, we talk about like study the things that really sort of irritate you, and bother you and rub you as a clinician. I think when there's synergy between those things, between your clinical practice and your research, I think it's really important. I very strongly believe in the, importance of the clinician scientist. There's a lot of, I think, forces that are making it more and more difficult to be a clinician scientist. And certainly our PhD colleagues have a lot of methodologic expertise that we can learn from and partner with them. But I think as clinicians, we provide the clinical perspective on the questions that are most pressing and relevant. And so just would encourage you all to engage in that work. I think some of the things that we just celebrated our 20th anniversary of our Center for Health Outcomes Policy, which is one of the most heavily funded units in the country. We celebrate our anniversary on Friday, and some of the things we talked about are, culture. We have a culture of a lot of generosity in terms of time and ideas. We'll send you anything you got a grant we'll send you anything we have. We believe in sort of making research fun and sharing ideas. And then I think focusing on writing. Writing is the currency of academia, and it's really important to communicate your ideas, get them out there and communicate them effectively.
Excellent. Questions for Dr. Dossett? Dr. Schulich.
So, Dr. Dossett, thank you so much for giving this wonderful presentation, for visiting us and being part of this research symposium today. So how much do you think that the people the doctors not following the recommendations, how much of it do you think is driven by the fear of not doing enough, of being sued, following the recommendations of how they were trained 10 years ago, versus, seeing an extra procedure in their procedure list, money, and, and so on? How do you break that down?
I think you're 100% correct. I think the majority of it has to do with fear. I think it's way easier for me as a surgical oncologist that sees nearly 100% cancer cases, and I see the spectrum and the range of cancer cases from the ones that we probably could leave alone and never have to treat, and the ones that, no matter our best intentions, we're not going to make a difference. And so being an expert in that, it's much easier to say like, oh yeah, this is a case where we just don't need to do these things. Whereas if you're a general surgeon out in the community and you're seeing you have a gallbladder and a colon and a thyroid on your schedule, sort of keeping up with those latest recommendations and being comfortable with those, I think is a big driver, and some of what we hope to address with some of our interventional strategies. And I think conversely, the idea that this is all driven by payment is just not borne out in the data, because if you look in the systems like the VA and the military health system where the clinicians are salaried and not productivity based, there's still a lot of overuse in those situations as well.
So I have two follow-ups to that. So are we working close enough with the American Board of Surgery, for example, where you have yearly requirements for refreshing what you know about surgery? And is that a good tool? And then my last question, you may or may not have done this, but let's say we followed the guidelines to, the 10 or 20% level versus 50 or 60% level. How much money would that save the American healthcare system? You may or may not have done that calculation.
Yeah, I haven't done it for the breast cancer work, but the estimates for the low value pre-op testing is in the $10 billion range, because even though those tests like EKGs and blood tests and things like that are inexpensive, it's the scale on which they're performed. And so it's like definitely real money. I think to get to your question about the board, I think one of the things that we've tried to do is make the case that as these organizations that define quality measures, as they're doing that they consider not just doing more measures, but doing less measures. And there's some evidence that is starting to happen. And a colleague at Michigan who's super involved in policy and value-based insurance design has wrote the cancer screening provision for the ACA. I was talking with him last week, and what CMS is CMS is like over this, right? Like they're very close to just not paying for preoperative testing, as one example, at all. And they really feel like that the payer strategy is part of it and key. But I think that I think that's the way to go, whether it be for the board, so when you research that a certain number of questions are not just about all the things that you should do, but the things you shouldn't be doing. And there's some examples where that information gets out quite rapidly, for example, de-implementation of completion lymph node dissection for melanoma patients. If you look at after MSLT2 was published, that the rates of dissection went to zero because I think clinicians know that can clearly see the harm to the patients. And so I think Gil Welch, who I alluded to, is just so poetic on talking about these concepts, gave just this phenomenal presentation that I saw last week. And he talked about this concept again of how much that really probably healthcare as an industry needs to contract a little bit to save a little bit, or at least not continue growing, to save money for those other sectors of our economy. And he said, we really need to train clinician detractors. And I thought that was a really interesting concept, that for the most part, we are trained to do more, you cover all our bases, think about how, you were trained as an intern to check every test and things like that. And that we really need to sort of, swing the pendulum a little bit to train clinician detractors, people that bring a skeptical eye to whether or not something actually is necessary and works.
Dr. McIntyre. Thanks so much for such an incredibly stimulating presentation. I want to go back to the financial incentive piece, and I'm very interested in what you said about the VA. But I've always had a hard time with this argument that physicians do a bunch of stuff because they're financially incentivized to do it. When one looks at physician workforce to population data, I don't see a lot of surgeons that are not already extremely busy without doing unnecessary procedures. But it was noticeably absent from all of your presentation about the personal financial incentive. Is that because in your early work, you didn't find it to be an incentive, or is it a survey question problem? Who's going to say, oh, I do all this unnecessary stuff because I make money doing it?
Yeah, there have been some other groups that have surveyed clinicians about some of these low value tests and treatments. And what clinicians say is their number one driver is the fear of lawsuits, which there's data that doesn't help you either. You can refute that as being a motivator. I think the individual physician, the individual physician being motivated by financial incentive is pretty low component of it. It's not zero. If you look at procedures like some of the endovascular stuff that's done for, vascular disease. There's certain areas in cardiology and whatnot where there's just, 10 times the magnitude of variation. And some of that has got, ultimately, systems, whether or not be the individual clinician, the systems are set up to, incentivize productivity. Everything is about getting the patient to the procedure. But again, I think the evidence from the VA, the military health system, Kaiser, where clinicians are salaried, really, and there's still persistent overuse, certainly indicates it's not the only driver.
Dr. Zakrzewski. And then we'll wrap up.
Thank you for sharing your data with us. This is a question about the minimizer maximizer survey data that you shared. So I'm a first generation doctor here, and my mom, who speaks very good English, if she were asked some of those questions that you shared with us, I would immediately be called and said, "Hey, how do I answer this? What do they want me to say?" And so I'm just curious what the demographics of those survey results were, and if you kind of took into account some of the cultural variation and English as a second language for those answers.
I can't remember. I think we excluded, you had to be English speaking. We did make sure that our demographics matched our population. So we did specifically recruit, for example, Black patients to match our, make sure that they were represented, even oversampled in our data. I think those are excellent questions. One of the sort of the developer of that measure, they've sort of tested and validated and explored these concepts in numerous clinical settings with numerous patient types, including some of the situations that you've talked on. I think it's, what I would say is that none of these things are as clean as we would like them to be, and sort of the one, the magic bullet. But I think the concept, right, of that there are patients that sort of have a range, and some patients are 100% comfortable and happy to omit these unnecessary treatments. So at a minimum, let's not do it in the ones that are already sort of there and are already minimizers. And I think if we can be more, I think it takes you don't even have to ask the question. It takes you a few minutes in terms of talking with a patient to sort of figure out where they are on that scale. And then you can sort of start to tailor your conversations to meet them where they are. And then I think also the important thing is recognizing that we have those tendencies as clinicians too, and to sort of be aware of that and constantly check, like, where is our practice as compared to our colleagues? And I think you don't want to be at the 98th percentile in utilization. This probably means you're utilizing some things.
Thank you so much again.
Thank you.
Excellent presentation.
Thank you.
That as a visiting professor, we have for you including a book on the history
Oh,
of the department
thank
by
you.
one of our faculty.
Thank you so much.